Hello everyone. In this class, we'll try to learn about tubular functions. The learning objective of this class would be to understand the common principles of tubular functions in urine formation, list the transport mechanism that operate along the kidney tubules, appreciate the basic transport mechanism that function across tubular epithelium, elucidate proximal tubular functions of loop of Henle, distal converted tubule, and collecting duct. Correlate the tubular functions with its dysfunctions, describe the mechanism of reabsorption of sodium and glucose from the kidney tubules, define tubular load, maximum transport, renal threshold, renal splay, and enumerate their significance. Understand the mechanism of water reabsorption from the different parts of the nephron. List the functions of P cell and I cell in collecting duct and describe the effect of aldosterone on the collecting duct functions. There are three steps of urine formation. First is ultrafiltration of plasma through the renal corpuscle, reabsorption of the water and solutes from the tubular fluid, then secretion of the secreted solutes into the tubular fluid. Thus, after glomerular filtration, tubular handling of the filtrate is the most important step in the process of urine formation. The glomerular filtration is a non-specific process in the sense that mechanism of filtration is not different of water and different solutes, whereas tubular transport are selective processes as solvent and different solutes are either reabsorbed or secreted by mechanisms specific to their transport. Tubular exchange of water and electrolytes finally determines the volume and composition of urine. Thus, tubular mechanism are most important processes in the determination of urine volume and composition. By modulating the reabsorption and secretion of substances of its luminal fluid, the renal tubule plays an important role in the control of composition, osmolality, pH, and volume of ECF. The glomerular filtration is 180 liters per day, whereas quantity of urine formed is about 1.5 liters per day, which is less than 1% of the glomerular filtrate. Thus, the renal tubules has vast capacity to reabsorb water and solutes. Usually, glucose and bicarbonate almost reabsorbed completely. Water, sodium, and chloride are reabsorbed more than 99%. Potassium reabsorbed more than 90%, and urea reabsorbed about 50% of the filtrate in the renal tubules. So this diagram showing the three steps of the urine formation: glomerular filtration, tubular reabsorption, and tubular secretion. The major function of the tubule is to reabsorb water and solutes from the tubular fluid, which is crucial for the water and electrolyte homeostasis of the body. These transport mechanisms of various substances are different in different parts of the kidney tubules. The glucose and bicarbonates, they are almost 100% reabsorbed. Sodium, chloride, water almost 99%, as well as potassium, they are absorbed 99%, and urea is absorbed around 50% of the filtrate. Transport mechanisms. Process of transport across tubular membrane can be broadly divided into two categories, that is passive transport and active transport. Transport of solutes involves both passive and active processes, whereas water absorption is a passive phenomenon. Coming to passive mechanisms, diffusion. The solutes are transported by means of diffusion from their area of higher concentration to the area of lower concentration. This is the transport along the chemical gradient. Especially uncharged solutes like glucose are transported by this mechanism. However, though charged solutes, especially ions, are also transported by diffusion, their electrical gradient greatly influences this passive transport. There can also be facilitated diffusion. In this transport mechanism, specific carrier protein in the membrane facilitates the process of diffusion. Reabsorption of glucose via glucose transporter is an example of facilitated diffusion. Sodium and transport ions are also reabsorbed from kidney tubule through the water-filled channels created by the carrier proteins. There are two mechanisms of coupled transport, symport mechanism and antiport mechanism. Symport mechanism is the process of coupled transport of two or more solutes in the same direction by carrier protein. The example are the transport of sodium and glucose, sodium and amino acids. The antiport mechanism is the process of coupled transport of two or more solutes in the opposite direction by a carrier protein. An example is sodium hydrogen exchange in the proximal tubule that reabsorbs sodium from the tubular fluid in exchange for secretion of H plus into it. When bulk of amount of water is reabsorbed, the solutes dissolved in water are also transported along with the water across the tubular epithelium, and this process is called as solvent drag. This contributes to reabsorption of substantial amount of solutes in the proximal tubule. When considerable amount of osmotically active solute is transported, water is reabsorbed along with it to maintain the osmotic balance, and this is called as osmosis. This is the major mechanism for reabsorption of water from tubular lumen. For example, water reabsorption follows reabsorption of sodium and chloride from the tubular fluid. Conversely, increased osmolality of the tubular fluid increases water excretion known as osmotic diuresis. Here are some uh, the active transport mechanisms. The transport of solutes is considered to be active when ATP is utilized in the process. In this mechanism, solutes are transported from area of lower concentration to the area of higher concentration. Some of the examples where active transport occurs in the tubules of the kidney are uh, in PCT, thick ascending loop, DCT and CD are sodium glucose, sodium phosphate, sodium amino acid, sodium lactate, sodium hydrogen exchanger, and in the thick ascending limb, sodium potassium chloride transport channel, sodium hydrogen exchanger potassium channel, whereas in DCT sodium chloride, whereas in CD epithelial sodium channels are some of the example for active transport. Secondary active transport can also occur here. In this mechanism, in which sodium, glucose, and associated solutes are reabsorbed from the kidney tubules. In active transport mechanism, the sodium potassium ATP is located in the basolateral uh, membrane of the epithelial cells that pumps out sodium out of the cells. This creates a low concentration of sodium in the tubular cells. Therefore, sodium is reabsorbed from the tubular fluid along with its concentration gradient into tubular cells. The carrier protein of sodium facilitates the reabsorption of sodium into tubular cells. Glucose is reabsorbed by the same carrier protein that reabsorbs sodium. Therefore, reabsorption of glucose by this mechanism is an example of secondary active transport. Similar mechanism operates in the epithelial cells of intestine. There can also be paracellular pathway of transport. Close to the apical membrane, tubular epithelial cells have tight junctions between them. Immediately after the tight junction between epithelial cells, the lateral intercellular space starts. However, these tight junctions are not very tight and they have a leaky channels. When transport of solutes and water occurs between the cells through tight junction and lateral intercellular space, the process is called as transport across the paracellular pathway. A considerable quantity of calcium, potassium are reabsorbed in the proximal tubule via paracellular pathway. Some amount of sodium and water is also reabsorbed via this route. So this is a diagram showing the mechanism of transcellular and paracellular pathway. The transcellular pathways, the substances which are across the tubular epithelial cells, and paracellular pathway is the substances which are absorbed across the tight junctions and the lateral uh, intercellular space. Coming to transport maximum, the transport system in the renal tubule, like transport system in other parts of the body, have their maximal rate, so which is called as transport maximum. This is the rate at which the tubule maximally transport a particular solute. That means the amount of particular solute transported depends on the amount of solute in the tubular fluid present up to the transport maximum for the solute. Transport maximum is the amount of substance delivered to the tubule per minute. When the concentration of the solute in tubular fluid is more than the tubular maximum concentration, the mechanism of transport is said to be saturated. And beyond this, there will be no appreciable increase in the transport of the solute. For example, the transport maximum for glucose is 375 milligrams per minute in males and 300 milligrams per minute in females. Tubular load, the quantity of a solute filtered by the glomerular capsular filtering membrane or barrier and presented to the tubular fluid, is tubular load. The tubular load determines the amount of substance to be reabsorbed from the tubule, as normally a constant fraction of the load is reabsorbed by the kidney tubules, which is called as glomerulotubular balance. Tubular load also determines the transport maximum of the substance. The amount of substrate delivered to the tubular fluid per unit time uh, greatly contributes to the maximum quantity of the substance that can be reabsorbed. However, transport maximum depends on the plasma concentration of the substance and the rate of filtration of the substance, that is, plasma concentration into GFR. For example, transport maximum for glucose is 375 milligrams per minute, which indicates that the plasma concentration of the glucose is up to 300 gram percent, and tubule can transport glucose totally from the tubular fluid. However, normally glucose appears in urine about 200 milligram percent. More accurately, above 180 milligram percent of venous blood, uh, and this is because the mechanism of renals play for glucose. Renal threshold, this is the concentration of the solute in the plasma at or above which the solute first appears in the urine or appears in more amount than its normal concentration. For example, normally glucose is not present in urine and its renal threshold is 180 milligram percent in venous plasma, that is 200 milligrams percent in arterial plasma. Therefore, glycosuria occurs when plasma concentration of glucose is above 180 milligram percent. Coming to the tubular function, proximal tubular functions. The proximal tubule is the most important part of nephron as it reabsorbs about 67% of the filtered water, sodium, chloride, potassium, and bicarbonates, and almost all the filtered glucose and amino acids. The proximal tubule has convoluted and straight portions. Though the convoluted part comprises of 70% of the tubules, functionally both parts are similar with few minor differences. The primary focus of reabsorption process in the proximal tubule is directed at sodium reabsorption, which is usually secondary to electrochemical gradient created by sodium potassium pump located in the basolateral membrane of the epithelial cell. Reabsorption of water and most of the solutes is directly or indirectly linked with sodium potassium pump. Therefore, abnormalities of this pump results in many renal dysfunctions. The fluid in the early part of the proximal tubule is almost osmotic to plasma. Sodium and its two major anions, chloride and bicarbonate, are the major solute in the plasma and glomerular filtrate. Bicarbonate is reabsorbed mainly in the converted portion of the proximal tubule, leading to its drastic fall in the rest of the tubule. Chloride is reabsorbed in the second half of the proximal tubule, that is the later part of the converted portion and straight portion, which creates a lumen positive transepithelial potential difference that favors the passive reabsorption of the sodium. About 67% of the filtered potassium is reabsorbed along with 67% of water. Glucose and amino acids are almost completely reabsorbed in the proximal tubule, resulting in their steep fall in the rest of the tubule. Thus, at the end of the proximal tubule, only one third of sodium, chloride, and potassium remain with almost absence of glucose, amino acids, and bicarbonate in the tubular fluid. However, urea concentration is increased as it is not at all absorbed in this part of the tubule. Coming to sodium reabsorption. In proximal tubule, reabsorption of sodium is important among all the transport processes as it generates the major driving force for reabsorption of water and other solids. From tubular fluid, sodium enters the tubular epithelial cells along the electrochemical gradient. Inside the tubular cells, concentration of sodium is about 35 milliequivalents per liter in comparison to 140 milliequivalents per liter in the tubular fluid. However, intracellular concentration of sodium is due to the activity of sodium potassium pump located on the basolateral surface of the cell. The sodium removed from the cell into the lateral intercellular space enters the interstitial fluid, and the potassium pumped into the cell diffuses out of it through the basolateral membrane and mostly via potassium channels. Thus, the net effect is increased sodium levels in the tubular cells. This causes sodium from tubular fluid to enter into the tubular cells. As the sodium entry from the luminal surface into the cells utilizes the energy generated by sodium potassium pump on the basolateral membrane, the process of sodium reabsorption is an active transport mechanism. About 67% of the filtered sodium is reabsorbed in the proximal tubule. From the tubular fluid, entry of sodium into the tubular cell occurs via various co-transport and anti-transport mechanisms that are located on the apical cell membrane. The carrier protein that transports sodium also co-transport glucose, amino acids, phosphates. Therefore, reabsorption of these solutes is considered as active secondary active transport. Sodium is also transported from tubular fluid by antipode, especially sodium hydrogen exchanger, which reabsorbs sodium into cell in exchange for secretion of H plus ion into the luminal fluid. Normally, sodium hydrogen exchanger is the primary mechanism of entry of sodium into epithelial cells, which accounts about 60% of the total sodium entry. There can be associated anion reabsorption. Sodium reabsorption is accompanied by reabsorption of anions such as bicarbonate, chloride to maintain electron neutrality. However, process of anion absorption along with sodium is different in first and second half the proximal tubule. In the first half of the proximal tubule, sodium reabsorption mainly associated with bicarbonate and organic solids like glucose. Thus, sodium and bicarbonate reabsorption in the first part of the PCT is coupled to the transport of organic molecules. Therefore, simultaneous reabsorption of sodium, bicarbonate, and organic solids from proximal tubular fluid establishes an osmotic gradient that results in reabsorption of water. In the second half of the proximal tubule, sodium reabsorption is mainly associated with chloride reabsorption via transcellular and paracellular pathway. In the later part of the proximal tubule, sodium reabsorption is coupled with chloride rather than bicarbonate or organic solids because of two reasons. The distal part of the proximal tubule concentration of the chloride is very high, whereas the concentration of glucose and amino acids is less. In this reason, as as sodium and bicarbonate are preferentially reabsorbed in the first part of the PCT. Also, presence of more chloride ions antiporter in the distal part of the proximal tubule facilitates transport of chloride into the cell. Sodium that enters the cell is pumped out of it to enter ECF via sodium potassium pump located on the basolateral membrane. The chloride leaves the cell by means of uh, potassium chloride symporter located on the basolateral membrane. Thus, sodium and chloride are reabsorbed from the tubular fluid into the interstitial fluid via tubular cells. This is called as transcellular pathway of reabsorption of solutes. Increased concentration of sodium in the lateral interstitial space creates electrical gradient for a chloride ion. Also, it moves through the paracellular pathway. This is because the tight junctions between tubular cells at their apical margin contain leaky channels that transport chloride along its electrical concentration gradient from tubular fluid into the interstitial space. This is called as paracellular pathway of reabsorption of solutes. This paracellular pathway of solute reabsorption constitutes about 25% of the sodium chloride reabsorption in the proximal tubule. Thus, sodium reabsorption helps in the reabsorption of the chloride, bicarbonate, and other cations and anions and various organic solutes. The transfer of organic and inorganic solutes from tubular fluid into the interstitial space creates the osmotic gradient for the reabsorption of water in the proximal tubule. So this is how the sodium is reabsorbed. It is mainly reabsorbed by uh, the secondary active transport, as the sodium potassium pump in the basolateral membrane creates the gradient for sodium, and the sodium can be transported by the co-transport with the other solutes, and it can be uh, anti-transported with the hydrogen. So sometimes the sodium hydrogen exchanger can be active pump, primary active pump. Normally 65% of the filtered water is reabsorbed in the PCT. The driving force of water reabsorption is the transcellular osmotic gradient, which is established by reabsorption of the sodium and accompanying solutes. The transcellular and paracellular reabsorption of the sodium chloride and other solutes from tubular fluid into the lateral intercellulars and interstitial spaces increases the osmolarity of the fluid in these spaces. Permeability of the epithelium of proximal tubule to water is extremely high. Water passes through epithelial cells via water channels, that is aquaporin 1, present in the cell membranes, and also through the water channels present in the paracellular route, that is tight junctions between the cells. Therefore, even smaller osmotic gradient result in adequate movement of water. Thus, the water flows along with the osmotic gradient via transcellular and paracellular pathways. Hence, reabsorption of water is coupled with reabsorption of solutes, especially with that of sodium and chloride. The transfer of large amount of water helps in transport of ions like potassium and calcium that are carried along with water, and this is called as solvent drag. Accumulation of water in the interstitial space increases the hydrostatic pressure that favors transfer of water from there into the extracellular fluid. The role of peritubular capillaries in absorption of water. The peritubular capillaries plays important role in the absorption of solutes and water from the tubule. Peritubular capillaries are derived from efferent arteriole and therefore they receive blood from the glomerulus. As the blood draining from the glomerulus has already been filtered in the glomerular capillary and protein has not been filtered through the filtration barrier in the renal corpuscle, blood in the peritubulary capillary has high oncotic pressure. Moreover, hydrostatic pressure also less in the peritubular capillaries as the blood has passed through the upstream resistance vessels before entering these capillaries. Thus, high oncotic and low hydrostatic pressure favor uptake of water from the interstitial tissue space surrounding the tubules. This transfer of water from peritubular space into the peritubular capillaries maintains the gradient for water reabsorption from tubular lumen. So this is how the water gets reabsorbed from the proximal convoluted tubule through the paracellular pathways and through the transcellular pathways. Coming to glucose reabsorption. Glucose is reabsorbed completely from tubular fluid in the proximal tubule. It is reabsorbed along sodium in the tubule. Sodium is pumped out of the tubular cells by sodium-potassium pump located in the basolateral membrane. The carrier protein that transport sodium also reabsorbs glucose, that is called as sodium glucose cotransporter. Thus, reabsorption of glucose from the luminal membrane is secondary transport to the active process located on the basolateral membrane of the cells and therefore is a typical example of secondary active transport. Glucose transport mechanism in the kidney is similar to that of transport of glucose in the intestine. The glucose and sodium bind to the sodium glucose transport 1 and 2, uh, that is a common carrier protein that transports sodium and glucose and many other solutes like amino acids, lactate and phosphates. This helps in the reabsorption of glucose along with sodium when sodium is reabsorbed into the tubular cells from the tubular fluid. From the cell, glucose is transported into the interstitial fluid by GLUT2 transporters. Thus, the glucose reabsorption is closely associated with sodium reabsorption. Transport maximum for glucose and renal splay. Glucose is filtered at the rate of 100 milligrams per minute. This is because the normal plasma glucose concentration is about 80 milligrams per deciliter and GFR is 125 ml per minute. However, almost all the filtered glucose is reabsorbed in the proximal tubule, so that in normal condition urine is essentially glucose free. The rate of reabsorption of glucose is proportional to the amount of glucose filtered. Therefore, plasma glucose level determines the transport maximum glucose. The normal TMG is 375 milligrams per minute in males and 300 milligrams per minute in female. When TMG is exceeded, the glucose appears in the urine, as the renal threshold is the TMG divided by GFR. The predicted value for the renal threshold will be about 300 milligrams per deciliter when TMG is 375 milligrams per minute and the GFR is 125 ml per minute. However, the actual renal threshold is much below the predicted value, that is about 200 milligrams per deciliter in the arterial plasma and 180 milligrams per deciliter in venous plasma. Therefore, when the graph of TMG is plotted, the actual curve deviates from the ideal curve. So this deviation is called as renal splay. So the splay occurs because of the two reasons, that is TMG is not same in all the tubules and the amount of glucose removed from each tubule is not complete even when the amount filtered is below the transport maximum of glucose. So this is how glucose is going to be reabsorbed by the secondary active transport in the proximal convoluted tubule. The active transport is present in the basolateral membrane that creates the gradient for sodium, and when the sodium moves inside, the glucose is also going to move along with the sodium, so by secondary active transport. And this diagram shows the transport maximum for glucose. Okay, so when it reaches to the certain level, when uh, all the carrier proteins are exhausted, then it reaches the TMG. However, the the actual and which the ideal TMG curve are different because all the nephrons they are not active at the same time, and this is called as splay. Normally, proteins do not appear in the urine as they are almost totally reabsorbed into the proximal tubule. The glomerulus filters only a small quantity of proteins in which is about 7 grams per day. Amino acids from the tubular fluid are also reabsorbed by means of carrier proteins that reabsorb sodium and glucose. Also, enzymes present on the apical membrane of the epithelial cells of PCT partially degrade the proteins and endocytosize them. The proteins in the cell are degraded by cellular enzymes into their respective amino acids. Amino acids are then transported from the cell across the basolateral membrane into the interstitial tissue space and from there into the blood. By these mechanisms, almost all the filtered proteins and amino acids are reabsorbed from the proximal tubule. Therefore, urine is practically protein free. But when amount of protein filtered is more or protein reabsorption is less, proteinuria occurs. Usually proteinuria occurs due to the disruption of the glomerular-filtrating membrane as it occurs in glomerulonephritis that increases the tubular load of proteins. Transport of organic solids. The proximal tubule secretes various organic cations and anions. Many of these ions are produced by metabolism such as uric acid. Many exogenous organic substances like PAH are also secreted by the proximal tubule. Usually, these organic compounds are bound to plasma proteins that prevent filtration of the substances via glomerular membrane. However, substances are transported from peritubular capillaries into the tubular cells from they where they are secreted into the tubular fluid. Therefore, excretion of this organic compound in urine via secretion by the tubular cells uh, constitutes an important mechanism for their elimination from the body. The interference of renal transport of organic compounds help in the treatment of many metabolic diseases. For example, gout, which occurs due to the accumulation of the uric acid in plasma. Therefore, aim of treatment of gout is to decrease the plasma uric acid level. Uric acid is both secreted and reabsorbed in the proximal tubule. Thus, one mechanism to decrease the uric acid level in gout is to promote its excretion by decreasing reabsorption from the PCT. pH is an organic anion secreted across the proximal tubular cells. The pathway for this secretion has a low specificity, which means many other organic anions like bile salts, oxalates, urates are also secreted by this mechanism. pH enters the proximal tubular cells via basolateral membrane in exchange for alpha ketoglutarate. That is via PAH alpha ketoglutarate antiport mechanism. Normally, the alpha ketoglutarate is the produced in the cell by the glutamate metabolism. The alpha ketoglutarate that comes out of the cell into the interstitial tissue space is taken back into the cells by sodium and alpha ketoglutarate sympone. pH is then taken into the tubular fluid along with concentration gradient. The mechanism that transports pH into the tubular cell is non-specific. Therefore, increased plasma concentration of one anion decreases the secretion of other. For example, urinary excretion of PAH decreases the individual receiving penicillin, and similarly, the excretion of the penicillin uh, decreases in individual receiving PH. Therefore, during World War II, when the availability of the penicillin was less, the penicillin was administered along with hippuric acid, which resulted in the prolonged action of penicillin by decreasing its secretion through the tubular cells. Thus, penicillin in low dose could achieve a desirable therapeutic effects. Defects in the proximal tubular reabsorption causes Fanconi syndrome. Chloride absorption. Chloride is mainly reabsorbed secondary to sodium reabsorption in the proximal connected tubule to maintain electron neutrality. Recently, separate chloride channels have been identified in the kidney tubules. It has been observed that these chloride channels are linked with uh, calcium channels, but how these two channels interact and operate is not clearly known. Defect in chloride channel causes dense disease. This is about uh, some of the functions of uh, the, the tubules. Thank you.